In this video, we'll present a simulation on a new model for classical cesarean section by Tiffany Lotan, David Rivera, Kelsey Pazerski, Andrew Bryant, and Tess Chase. Classical cesarean section accounts for approximately 1% of cesarean births. It is associated with an increased risk for uterine rupture in subsequent pregnancies due to involvement of the contractile portion of the uterus or myometrium. Indications for classical cesarean section include underdeveloped lower uterine segments, fetal malpresentation such as transverse lie with an impacted shoulder, or back-down presentation, fetal anomalies such as macrocephaly, structural anomalies obstructing access to the lower uterine segment such as fibroids, or severe adhesive disease such as bladder adhesion to the lower uterine segment with concern for bladder injury. Our model replicates realistic abdominal wall and uterine anatomy, placental location, and allows trainees to perform a complete classical cesarean section, including vertical hysterotomy and multi-layer uterine closure with serosal baseball stitch technique. By providing simulated practice, the goal is to increase trainees' comfort and competence. This novel simulation model aims to improve residents' comfort and technical skills with classical incisions, address provider discomfort by offering realistic and accurate anatomical layers, and allow trainees to practice incision, delivery, and closure in a safe but realistic environment. Here is a cost breakdown for all materials required for the simulation that cannot be found in a hospital setting, as well as their ability for reuse. Of note, commercially available abdominal wall models are available, however, their cost is upwards of $250 with minimal ability for reuse. Pictured here are all gathered and assembled materials for the simulation. Uterine assembly is accomplished by placing one balloon inside of the other and then filling with placenta, baby, and fluid, followed by assembly of the abdominal cavity. A cesarean section tray that could be re-sterilized as well as discarded or expired sutures were gathered from labor and delivery for completion of the simulation. Pictured here is the fully assembled model. A fan and steel skin incision is made 3 centimeters above the pubic symphysis and extended laterally approximately 12 to 15 centimeters. Sharp dissection is then continued through the subcutaneous layer down to the fascia. The fascia is then incised sharply at the midline using the scalpel. Bony pickups and curved mayos are then used to extend the fascial incision laterally on both sides with the aid of the surgical assistant. Coker clamps are then used to grasp the fascial edge in the inferior portion, separating the fascia from the underlying rectus abdominal muscles, and the same procedure is repeated on the superior aspect of the fascia as well. The peritoneal layer is then grasped with pickups, and a small incision is made using Metzenbaum scissors, which is then extended bluntly with the aid of the assistant. A bladder blade and Richardson retractor are then inserted to facilitate visualization of the uterus. A scalpel is then used to create a vertical midline incision in the anterior wall of the uterus, taking great care to avoid injury to the fetus. Although not pictured here, Alice clamps may be used to grasp the myometrium on either side of the hysterotomy and elevate it away from the amniotic sac while making the hysterotomy to avoid incidental amniotomy. Once the uterine cavity is entered with a scalpel, the surgeon inserts 2 fingers through the hysterotomy site in order to create a plane between the fetus and myometrium, and bandage scissors are then used to extend the uterine hysterotomy, both cephalad and caudad if necessary, to facilitate in delivery of both the fetus and the placenta. The uterus is then exteriorized, cleaned with a lap sponge, and the bladder blade is reinserted prior to closure of the hysterotomy. In this model, the myometrium is closed using a single running layer of 0 vicryl. However, in actuality, due to thickness of the myometrium, it is not uncommon for the myometrium to require a 2-layer closure, with a deeper layer followed by another more superficial layer. To achieve good approximation and prevent the suture from tearing through the myometrium, it may be helpful to ask your assistant to relieve some of the tension by compressing the hysterotomy site on either side while the suture is being placed. The uterine serosa is then reapproximated using a 2O vicryl on an SH needle in the baseball stitch technique. The needle is passed through the cut edge of the serosa and then extended laterally to the hysterotomy site, repeating the same technique on the opposite side and carried down until the entire hysterotomy site is closed. This technique improves hemostasis and helps reduce adhesion formation. The patient is at most risk for blood loss during the time of multi-layer uterine closure. During this point in the cesarean section, it is imperative to communicate with the anesthesia team that Pitocin has been given and if any additional uterotonic or blood products are necessary. The surgical assistant may be helpful at this point in assessing uterine tone for need for uterotonics. Once past the inferior apex of the hysterotomy site, the suture is then tied and cut. The uterus is then replaced into the abdominal cavity, and the bladder blade and Richardson retractor are then removed. A small Richardson, Army, Navy, or Goulet retractor can then be used to expose the lateral fascial edge, a Coker clamp is used to grasp the fascial edge, and a 0 vicryl on a CT1 needle is used to reapproximate the fascia in a continuous, non-locked fashion. In patients at greater risk for wound dehiscence, a monofilament suture such as zero-loop PDS may be used in lieu of vicryl suture to close the fascia. To aid in visualization and closure, the surgical assistant may use a Coker clamp to grasp the opposite edge of the fascia. Some surgeons prefer to elevate the fascia by pulling upwards on the Coker clamp, helping to lift it away from underlying structures and reduce the risk for inadvertent injury. Once the fascia is fully approximated, the suture is tied, and the surgical assistant removes the Coker clamp as the first knot is cinched down. A 3O vicryl on a CT1 needle is then used to reapproximate the subcutaneous tissue in a running, non-locked fashion. This step is indicated if subcutaneous tissue has a depth of 2 centimeters or greater, but can be performed at less than 2 centimeters in depth for the purpose of cosmesis or better reapproximation of the incision. If the subcutaneous tissue cannot be well approximated in a one-layer closure, a multi-layer closure may be warranted to eliminate potential dead space and reduce the risk for seroma formation. The skin is then reapproximated using fluoromonacryl on a PS1 needle in a subcuticular fashion. To optimize cosmetic outcomes during skin closure, it's important to minimize tension on the wound by ensuring proper tissue alignment and taking small, evenly spaced bites in the dermal-epidermal junction. In patients with a history of keloid or hypertrophic scarring, intradermal Kenalog may be considered to reduce abnormal scar formation. Additional techniques to enhance cosmetic results include avoiding excessive manipulation of the skin edges, gentle skin retraction, and minimizing electrocautery at the dermal level. Classical cesarean section allows the benefit of easier delivery of the fetus, avoidance of bladder injury, and avoidance of injury to the uterine arteries. It is associated with increased blood loss, more difficult uterine closure, higher rates of post-operative infection, and greater risk of uterine rupture. The rate of uterine rupture after a classical cesarean section is between 4 to 12%, and therefore is an absolute contraindication to a trial of labor after cesarean. As such, recommendation is for repeat cesarean section between 36 weeks 0 days to 37 weeks 0 days gestational age in all subsequent pregnancies.